Welcome to the deep dive. Before we dive in, let's just take a moment together. If it feels good, close your eyes, or maybe just soften your gaze, and take a deep breath in and out. Let's think of one thing we're grateful for today, big or small. Could be your morning coffee, a loved one, or even just showing up here to learn something new. Thank you for being here. Let's get started. Today, we're tackling a topic that feels, well, incredibly urgent, especially given some recent reports. We're seeing a truly concerning surge in the rates of syphilis, gonorrhea, and chlamydia across the U.S. In fact, the CDC's Morbidity and Mortality Weekly Report from just June 6, 2024, calls this an ongoing STI epidemic. It really highlights a critical need for new strategies. So let me ask you this. What if one pill taken after sex could significantly lower your chances of getting an STI? That's precisely what we're here to explore today. Doxycycline Postexposure Prophylaxis, or DoxyPP. It's a new tool entering the arena in the fight against these bacterial infections. Our deep dive is based on the very latest 2024 CDC clinical guidelines. So we're talking crucial, up-to-the-minute information for both patients and healthcare providers.
It's true. The rising rates are a significant public health challenge, absolutely. And what's particularly exciting here, I think, is how science continues to give us these innovative ways to tackle persistent health issues. DoxyPEP is really an excellent example of our evolving understanding and our approach.
Okay, so the core finding from this 2024 CDC update is, well, it's really compelling. What are the key numbers we need to understand about doxycycline 200 milligrams efficacy, when taken after sex, particularly for syphilis, chlamydia, and gonorrhea?
Yeah, the data is quite clear on that. The studies show that a single 200 milligram dose of doxycycline taken within 72 hours of sex can significantly reduce the risk of acquiring certain STIs. We're looking at over a 70% reduction for syphilis and chlamydia.
Wow, over 70%.
Exactly, and approximately a 50% reduction for gonorrhea. What's fascinating here is that this isn't just, a marginal improvement. It really represents a substantial new layer of protection.
That's a huge impact. It really is. And it underscores something crucial. For these common bacterial STIs, syphilis, chlamydia, gonorrhea, we don't have vaccines. Our prevention options have, well, historically been pretty limited, right? Mostly things like condoms and regular testing.
Yeah.
This feels like it could be a potential game changer.
Absolutely. And the absence of vaccines for these specific bacterial STIs, it truly highlights the significance of a new chemoprophylaxis option like DoxyPP. It really does fill a critical gap, particularly for populations that are disproportionately affected. And just to clarify, PP, post-exposure prophylaxis, that's taken after a potential exposure.
What's after?
Yeah, distinct from pre-exposure prophylaxis, which is taken before. Now, doxycycline has been used as pre-P or PP for things like malaria and Lyme disease, but using it as PP specifically for bacterial STIs is, it's a novel and very welcome approach. It's also vital, really vital, to remember that DoxyPP is designed to be part of a comprehensive sexual health approach. It's never meant to be a standalone solution.
Okay, comprehensive. Got it. So who is DoxyPP primarily recommended for then? The CDC guidelines seem quite specific about who this intervention is really intended for. Could you break down those recommendations for us?
Certainly. The primary recommendation is for gay, bisexual, and other men who have sex with men, often referred to as MSM, and for transgender women, or PGW, and specifically those individuals who have had a bacterial STI, so that's syphilis, chlamydia, or gonorrhea, diagnosed in the past 12 months.
Okay, diagnosed in the past year. And what's the thinking, the rationale behind focusing on these specific groups?
Well, it's very much a data-driven approach. Studies like iPerGay, the DoxyPEP trial, which was done in San Francisco and Seattle, and the ANRS DoxYvac study. That last one was actually stopped early because it was so clearly effective.
Stopped early, wow.
Yeah. All these studies focused on these populations and consistently showed significant reductions in bacterial STI acquisition. These groups, they account for a high proportion of bacterial STIs. And focusing on those with a recent STI diagnosis turns out to be the most, let's say, efficient strategy for averting new infections. For instance, one study highlighted that just 25% of MSM accounted for something like 76% of bacterial STIs. The guidelines also, importantly, use very careful, nuanced language around gender identity, sexual orientation, and behavior. They acknowledge these are distinct and important concepts.
Right. So for other populations like cisgender women, heterosexual men, trans men, and maybe non-binary individuals assigned female at birth, AFAB individuals, the data are currently, quite limited. I know there was that Kenyan trial you mentioned, which showed no significant reduction in cisgender women. What did that tell us?
That Kenyan trial, conducted from 2020 to 2022, it indeed showed no significant reduction in bacterial STIs among cisgender women. The reasons for this are still being explored, really, but suspected non-adherence was a factor. Only about 29% participants in the doxycycline arm actually had the drug detected in hair studies.
Interesting.
Yeah, and biologic differences might also play a role. We don't know for sure yet. So for these other populations, the CDC really emphasizes shared decision-making based on clinical judgment. And this just reinforces the importance of, patient autonomy and personalized care, even when the data might be less robust.
Okay, that makes sense. Shared decision-making. And hey, if this deep dive is sparking your curiosity or you're finding it helpful, a quick like or subscribe really helps us share these insights with more listeners, and maybe share it with someone who might need this info. Thanks. All right, let's get into the practical side of things. How does DoxyPP actually work? Like, how is it taken, and what's the dosage recommendation?
Okay, the dosage is a single 200 milligram dose of doxycycline. That's taken ideally within 24 hours, but definitely no later than 72 hours after oral, vaginal, or anal sex. And a crucial point to remember, don't exceed a maximum of 200 milligram a dose every 24 hours.
1 dose per 24 hours max.
Yeah.
Pretty straightforward. And I think the kind of brilliant part here is that providers prescribe it in advance, right? So patients can self-administer when needed. What does the ongoing clinical care look like for someone using DoxyPP?
Yeah, the patient-managed aspect is definitely empowering, but this strategy does rely heavily on adherence. The DoxyPep study showed pretty strong self-reported adherence, which was good, but in contrast, that suspected non-adherence in the Kenyan study, that was likely a factor in its lack of efficacy. So for the best effect, it's really critical to stress taking it as soon as possible within that 72-hour window. As for ongoing care, patients should undergo bacterial STI testing at all anatomic sites of exposure, that's important, and HIV screening every 3 to 6 months. Providers should also reevaluate the ongoing need for DoxyPP at these same 3 to 6 month intervals, and they should prescribe enough doses to last until the patient's next follow-up visit based on, their anticipated sexual activity.
Okay. So like any medication, DoxyPP comes with benefits and potential risks. On the benefit side, we've talked about that strong reduction in syphilis and chlamydia, over 70%, and the moderate reduction in gonorrhea, around 50%. This clearly positions it as a powerful additional tool. But what about the risks? What are the common side effects reported in the trials?
The benefits are, as you say, very compelling. They offer a significant layer of protection. Regarding side effects, the clinical trials, Ibergay, Doxypep, Antares, Doxyvac, they primarily reported gastrointestinal upset, so things like nausea, maybe vomiting or diarrhea, esophageal irritation or ulceration, and photosensitivity, meaning increased sensitivity to the sun, were also noted. The good news is most adverse effects tend to resolve if you stop taking it, and rare serious side effects are indeed uncommon.
That's helpful to know. But, a critical concern that often comes up with antibiotics is the potential for antimicrobial resistance. How does DoxyPP factor into that? Especially thinking about Neisseria gonorrhea and maybe Staphylococcus aureus, and maybe a related point. For some, the idea of taking a pill after sex might feel like it shifts responsibility or maybe even encourages riskier behavior. How do the guidelines kind of address those broader social or behavioral implications while still acknowledging the clear benefits?
That's a really vital question, and it's one the CDC guidelines absolutely grapple with directly. While there's that clear benefit in STI reduction, the potential for resistance, especially in gonorrhea, is a serious consideration. We saw hints of this in the studies. The Doxypep study, for example, found an increase in tetracycline-resistant Staphylococcus aureus, that's S. aureus in the nose, among those in the PP arm, even though overall S. aureus carriage actually decreased. A bit complex there.
Okay.
And Neisseria gonorrhea tetracycline resistance was also observed in both the Doxypep and ANRS Doxyvac studies. So the CDC recognizes this. They absolutely emphasize ongoing monitoring as these guidelines are implemented. It's a careful balancing act, really, between the immediate public health benefit and that long-term antimicrobial stewardship. And regarding behavior, the guidelines really aim to empower individuals with more tools for prevention. The idea isn't to lessen the importance of comprehensive sexual health practices, but to add another layer.
Okay, so it's about adding tools, not replacing responsibility.
Exactly. And to help mitigate side effects, the guidelines offer some practical tips for patients. Take the pill with food and a full glass of water. Don't lie down for at least an hour after taking it. And avoid dairy products or antacids about 2 hours before or after taking it, just to prevent drug interactions. The potential long-term effects on the microbiome are also highlighted by the CDC as an area needing more study and monitoring. It shows a cautious, evidence-based approach, I think.
Right, and it's so crucial to remember, as you said earlier, DoxyPP isn't a silver bullet. It's part of a much larger picture, a comprehensive sexual health strategy. What are some of those other key components that DoxyPP should always be offered alongside, according to the CDC guidelines?
You're absolutely right. It enhances rather than replaces existing prevention strategies. It's all about building layers of protection. So DoxyPP should always be offered alongside consistent and correct condom use, HIV PrEP or ongoing HIV care for people living with HIV, regular STI and HIV screening every 3 to 6 months, and also recommended vaccinations, including hepatitis A, hepatitis B, HPV, and Mpox. Critical thinking is essential here. No single tool is perfect, but together they create a much more robust defense.
So what does this all mean for you listening? It's really about empowering your choices and providing more layers of protection within your own sexual health journey.
Exactly. That's the goal. Provide more options for protection. Allow individuals, in consultation with their providers, to make informed decisions that best suit their lives and their risk profiles. This also includes things like risk reduction counseling, assessing if someone needs HIV PP if they aren't already on PPP, and considering other ancillary services too, things like screening for hepatitis B and C, and maybe referrals for primary care or mental health services if needed. It's holistic.
Absolutely. Okay, as we start to wrap up our deep dive, let's try and distill this into some actionable takeaways for two key audiences, patients and clinicians. So for patients listening, if you are a gay, bisexual, or other man who has sex with men, or a transgender woman, and you've had a bacterial STI in the past year, this is definitely a conversation worth having with your healthcare provider. Ask them about DoxyPP. Remember, it's one pill, used after sex. It's not an everyday medication like some PrEP regimens, and it's not necessarily something you take forever. And be aware of the potential side effects we talked about, like stomach upset or sun sensitivity, and know how to take it safely, ideally with food and water, and avoiding lying down right after.
And for clinicians listening in, the CDC guidelines recommend proactively counseling MSM and TGW with a recent STI diagnosis about DoxyPP. Really engage in shared decision-making with your patients. When prescribing, make sure to prescribe enough doses to last until the patient's next follow-up based on their anticipated sexual activity. Screen regularly for STIs and HIV every 3 to 6 months and reevaluate the ongoing need for DoxyPP at each of those visits. And for populations outside that primary recommendation group, use your clinical judgment and that shared decision-making framework to guide those discussions carefully.
Perfect summary. As we wrap up, I just want to say thank you again for spending this time with us. Remember, your health and your knowledge are truly powerful tools. If you haven't already and found this valuable, please like, subscribe, and maybe turn on notifications so you don't miss future deep dives. And most importantly, share this with someone who could use these insights. It could really make a difference. So, what's the bottom line? DoxyPP won't end the STI epidemic on its own, obviously, but it's an important new tool we can use together. Patients should feel empowered to ask about it, and providers should be ready to guide safe, evidence-based use, all within that comprehensive sexual health strategy.
And that really raises a crucial question, maybe for you listening to consider. As we see these new prevention strategies emerge, how can we each contribute to fostering more open, more informed conversations about sexual health in our communities? It's really about breaking down barriers and empowering everyone with knowledge, recognizing the dynamic nature of public health and the absolute necessity of continuous learning and adaptation.